I'm very excited to share with you all today a little bit of our work that speaks to this big question of how do we address the crisis that we're facing in suicide, particularly in young people, given the focus of my lab's work, through brief digital interventions. Quick slide on disclosures. Very grateful for all the support that we've received for this work. On the bottom there is a little bit of additional information about books and things. Okay, so we know that what we're doing currently to meet the needs of people with suicidal thoughts and behaviors, which I'll call STBs, is simply not sufficient to meet the needs of the population at scale. In a national study of US adolescents, more than 2/3 of teenagers with past year suicidal ideation and more than half with a past year suicide attempt had zero contact with a mental health specialist in the past year, which suggests that the vast majority of risk is going undetected and unaddressed. And there are definitely many reasons for this discrepancy, but I would argue that one set of reasons is because of the existing interventions that we have for mental health, and particularly for STBs in young people, aren't built to match the needs that youth have for convenience, autonomy, and flexibility in the kind of care that they access and receive. First of all, as is clear from that prior statistic, supports just aren't located where youth are most likely to seek help first, which is online, either through social media or Google searches, or through forums where they can ask others about their experiences with coping. Another big reason is that youth are actually structurally disempowered to access support for STBs on their own. In our work, we've found that 32 to 42% of teens who could not access care for serious emotional and behavioral problems cited their parents as the primary barrier to accessing treatment. One of the big themes among STBs was a fear of forced disclosure that prevents help seeking in young people because they're not sure how their parents or families are going to react, whether it'll be positive or whether it might really make things worse. And finally, the interventions that do exist, especially for STBs, are exceptionally high intensity and often opaque in terms of what youth know and what they're going to expect to be part of the treatment. So when we speak to young people in our work about what they want from mental health support, and that includes STB support, they tell us that they want to engage when and how they need it, as needed, not necessarily continuously over time, which is how most psychotherapies, including many that target STBs, have been structured to date. So we really need accessible, well-targeted supports for youth STBs that can empower youth to access that support when and how they want it, that can both reduce risk factors for STBs and also increase uptake of further support, given the hesitancy and the fears that prevent youth from doing this. And we need supports that can offer something with scientific support to those who would otherwise access nothing at all. The way that we in our lab approach this problem is by studying and disseminating single session interventions, or SSIs. These are specific structured programs that intentionally involve just one visit or encounter with a clinic, provider, or program. They importantly can be accessed once or on many occasions. That is, these are as needed supports, one at a time supports, not one and done supports. It's not assumed that one single session will solve all problems. That's not reasonable or realistic, but there is the expectation that it can make a meaningful change. They can be self-guided, which it refers to most of the digital SSIs that we've studied, or human facilitated, and they can exist within or outside healthcare settings. But in all cases, SSIs drop this often false assumption that people always will return for session 2, which is an especially false assumption in STB treatment, and instill the belief that meaningful change is possible at any moment, even if that moment is very brief. And I want to emphasize that I don't believe and I don't want SSIs to replace any other forms of healthcare treatment that are already available to folks. But since we know those aren't sufficient and never will be to bridge the gaps we're facing, we really need treatments like SSIs to fill these unfillable gaps that we're facing in healthcare ecosystems worldwide. This is a study we're just about to submit for peer review. I'm very excited. We recently conducted an umbrella review of all systematic reviews and meta-analyses of single session interventions to date. And as it turns out, there are 24 such systematic reviews or meta-analyses, and 20 of them report overall SSI benefits for either mental health outcomes or service use outcomes. One of those reviews specifically focused on folks with STBs and found that single session interventions, although provider delivered in this study, were significantly and consistently, as in 100% of the time, associated with increased connection with further services when offered in the emergency department. Interestingly, when we directly compared SSIs to multi-session therapies, which 4 of these meta-analyses did, multi-sessions outperformed SSIs in just 1 of them. And the overall SSI effect, a second-order meta-analytic effect that we found, was 0.25, so a small effect on average, but something that can be magnified at scale if scaled to the population. And this is just a forest plot of what we found across different studies. We've been doing this work for quite some time, and at this point, our lab's evidence-based SSIs have served more than 60,000 young people, most through nonprofit and community partnerships, including industry partnerships. Importantly, our SSIs are accessible as needed, with or without parent involvement, and that's especially important for STB interventions, because youth can be sure that their privacy will be maintained. We have a bunch of different interventions, but overall, the studies that we've conducted to date have shown that digital SSIs can reduce risk factors for STBs up to 3 to 9 months later. They can support safety plan creation and use, and they can increase uptake of crisis supports. And before I share more about the evidence for those statements, I want to share about what we think of as the generalizable theory of change underlying our single session interventions that are found to be effective. We understand the change mechanisms through the lens of self-determination theory. That is, humans have basic psychological needs to feel autonomous, competent, and related or understood by others around them. And when those needs are fulfilled, behavior change becomes possible. And we've found that autonomy, competence, and relatedness are targeted and shifted by SSIs. Specifically by providing psychoeducation, including positioning the user as the expert, which promotes autonomy. We offer stories from peers and invitations to provide advice to others to enhance relatedness. And we include action plans in our SSIs to enhance competence in using a skill that we're teaching. In turn, those change mechanisms lead to proximal improvements in less hopelessness, less internalized stigma, depending on the intervention, more agency and motivation. And what we found is that the distal outcomes that result from this are increased service use, such as crisis resource uptake, and fewer mental health problems, such as depression and anxiety, which of course are risk factors for STBs. What we haven't yet found is an SSI targeting STBs directly, but this is an area that I'm very excited, and hopefully folks in this audience are excited to explore further in future work. As one example, we found in a large RCT, including 2,452 teens ages 13 to 16 across all 50 states, that SSIs, two digital SSIs, one teaching growth mindset and one teaching behavioral activation, can reduce hopelessness, depression, and strengthen agency in youth 3 months later. This sample was quite diverse, 80% LGBTQ, 20% gender diverse, 50% racial or ethnically minoritized. We found both short-term and 3-month effects on hopelessness and depression. We also found in a study we're writing up now that shifts in hopelessness and agency in the short term actually explained variance in 3 months change in depression, suggesting these things as mechanisms. We also have found in a recent study led by Riley McDonnell in clinical psych science that effects did not differ by race, gender, or sexual orientation, suggesting that these digital SSIs can perform equitably across underserved groups, particularly when it comes to STBs. Notably, 60% of this sample did endorse STBs. However, we weren't focused on STBs as an outcome in this study, but what we do have is evidence that we can meaningfully address risk factors for STBs from this project. Another important set of risk factors for STBs, especially for minoritized youth, involves internalized stigma and identity pride, which can be risk or protective factors for this population. Here, we found a randomized trial teaching about minority stress theory to LGBTQ+ teens, who represent a very large portion of who accesses our SSIs, with significantly improved hopelessness, self-hate, internalized stigma, and identity pride, with the internalized stigma effect lasting until 2 weeks later compared to an active control. So we can also address identity-related risk factors for STBs through SSIs. In several of our studies, in collaboration with Catherine Fox, we've used a digital SSI as a self-guided safety planning tool in many of our SSI trials targeting depression. As in, this safety planning SSI was offered to all youth who endorse any STBs in our trials. And across 3 different studies, participants who endorsed STBs were offered personal outreach or safety planning SSI, which was a self-guided thing. And teens were 5 times as likely to request the digital safety planning tool versus personal outreach from our team, which I think suggests the acceptability of these kinds of tools at reaching youth in need. A follow-up study led by Catherine Fox's lab, on which I was a collaborator, looked at offering the safety planning SSI to 322 adolescents and follow up with 122 a month later. We found the safety planning SSI was very acceptable. And 1 month later, a third of those participants reported using their safety plan at some point. Those who generally didn't think it would help, which suggests to me a modifiable target of hopelessness that may be addressed in future iterations of this project. A good portion of our work is focused on partnering with agencies that have reach that academics will never have to improve the scaling of these interventions. So what we wanted to do with a nonprofit called COCO, led by Dr. Rob Morris, is embed our SSIs directly into social media as just-in-time support so they can reach people based on their search terms and needs. So we did embed our SSIs after shortening them considerably, because 6 minutes is the most time somebody will spend on an online tool without being paid for a study. And we found that with even with the reduced length, our SSIs significantly reduced hopelessness and significantly reduced desire or increased desire to stop self-harm when embedded into Tumblr across over 6,000 young people. Completion rates were much higher when the 6-minute versions and the longer versions, which is not surprising. It's just shorter and easier to do. We've also found that SSIs can increase uptake of crisis supports. Again, in a study with COCO, we wanted to see if we could do better than the standard status quo approach that these social media platforms take to preventing suicide, which is offering hotlines and text lines with no context. Most people who get this pop-up when they search for suicide do not use these tools. We wanted to see if a 1-minute SSI that includes those core self-determination theory components could boost in the moment uptake of online crisis resources. And we found that 10 minutes after receiving a 1-minute SSI plus these resources versus just the resources, which is the standard for all social media platforms, we saw a doubling in uptake of crisis resources within 10 minutes among 355 participants. I also want to highlight that there are major structural barriers that we need to consider, particularly that of parent involvement. Parents are cited as the primary barrier to youth accessing care, and for STBs, that is especially true due to fears of forced disclosure. Currently, we have grants from the NIH Office of Science Policy and from Hope Lab to better understand how teens view these policies that prevent teens from accessing care independently at various states in the US. And hopefully we're going to be building a digital dashboard to guide both clinicians and teens and parents in navigating the policy landscape and advocating for change in directions that give them more autonomy. So takeaways and recommendations. I think we can integrate evidence-based SSIs that we know mitigate STD risk factors as just-in-time supports where youth already seek care. We can use SSIs, digital SSIs, as accessible on-ramps to further care. We can embed digital safety planning SSIs into DMHIs that don't target suicide, since often those kinds of apps and supports don't include any STB support whatsoever. And we can test whether SSIs actually reduce STBs themselves over time, independently or in conjunction with other care, while also dismantling these structural barriers that we know are going to ultimately be the determinant, no matter how scalable our interventions are, in teens accessing the support they need. Thank you so much to my lab. Special thanks to Catherine Fox, my collaborator in much of this work. And thank you to the center for allowing me to share this today.